then you can go ahead and get started.
All right. So I'm Oliver Berdeen. I have a little bit of allergies, so my voice is a little hoarse. So I apologize for that. So I see that we really only have a little bit over 90 minutes until 2 o'clock. So I'm still willing to take questions throughout, and I may jot your questions down and then email out some responses as well, just so that I get through the content of the slides. But if you have a burning question, please ask it. And then my contact information is on the last slide, and you can always email or call after the webinar if you have any other questions. So I just wanted to do that, and then we'll move on to the timeline. Jess, could you move the slide ahead, please? Thank you. So we're just going to do an introduction about the program that I run in Portland, a little background on that, specifically not so much about me, but the program. And then we're going to talk about law enforcement and how they interact with mental health calls, substance use calls, and co-occurring calls, as well as how to respond to mental health crisis yourself or substance use crisis. I use the term substance use crisis for really anything where somebody is in a crisis, but the nexus is really a substance use. So that could be an overdose, which is also a medical crisis, but I use the term substance use crisis. I'll explain that a little bit more later. The current status of the opioid crisis in Cumberland County. Most of what I'm talking about is going to be Cumberland County centric, although a lot of it will apply to the whole state. There's some state laws that we'll be discussing, so that'll be universal. And then the current substance use trends, once again, that's what I'm seeing literally on the street with people, and what we're responding to and what we're seeing as issues. And then hopefully some solutions, or at the very least some tools for you to use. They'll be applicable to people that are licensed, people that are family members, concerned citizens. So I tried to make it clinical information, but with a non-clinical solution, so that everyone can participate and encourage changes in the community. And then some ideas of where we can go from here as state. So law enforcement, no, that's fine. So I run the law enforcement, excuse me, addiction advocacy program, or LEAP. And what it is it was started in a direct response to July 2015, when we had 14 overdoses in Portland, and 2 of them were fatal overdoses. And the chief of police here said, I don't want that to continue, and the only thing I can really do as a police chief is try to create a position to help, right? So we had an established co-responder model. In fact, we're nationally recognized for having a team of clinicians that respond with police and fire in the moment. So they respond in real time, sometimes at the very beginning of the call for service. And they have a police radio and an unmarked police car, and they help everyone get through traditionally a mental health crisis. So the chief and the director of that program decided we want to have a position that does the same thing, but for substance use crisis or an opioid overdose. So primarily my function in the beginning was to respond with officers to overdose calls and help officers, fire department, the person that overdosed, and everyone through that process. Someone trying to ask a question, or are they just not muted? No, okay. And so that position was created in February 2016, and that position was filled by me. I'm the only person in the law enforcement addiction advocacy program. It's just one position, with the hope that eventually we'll either have some peer support or recovery coaches, or more clinicians to help bolster that workforce. And the primary focus is really diversion from jail, safety, and engagement. We tried to adopt the LEAD model from Seattle, which has a lot of diversion involved, and we just couldn't make it applicable in Portland with the current environment. And so the chief said, well, I'm not going to just not do anything. I'm going to create something. So he created this position, and we had the infrastructure to do it. He paid for it initially with drug forfeiture money. So money that MDA took from people selling drugs, paid for the position for a year. We got a grant, and then actually that grant is running out, and he's back to paying for it with drug forfeiture money at this time. The program has worked with 200 unduplicated people, actually over that at this point. And that means face-to-face interaction. About 100 successful referrals to treatment or recovery resources. That means that the person was referred directly by me to a service. Lots of people are also successfully referred to treatment, but I don't count other providers in the community's successes as my success. And then, I only really track face-to-face encounters directly because those become people that become my clients. But in addition, people call the office phone or my cell phone requesting support or ideas for their loved ones or for themselves. And so about another 250 people have called over the last few years looking for support. And then it's really a wellness-based program. The idea is that we're working on substance use, but we're really working on wellness. And so some of the people that I work with are still using substances. And while abstinence could be a goal, long-term goal, it is not a requirement for the program. In fact, lots of people are still actively using, and I continue to work with them, even though I work for the police department. You can advance the slides. Thanks. All right, so we're going to dive right in. Once again, there's a lot of content, so I'll just power through. And so we're going to talk about law enforcement and mental health. And this one will be focused mostly on the greater Portland area, so Cumberland County, but will also apply to the rest of the state, especially this crisis intervention team training. So in our state, NAMI helps put on the crisis intervention team training, which is a 40-hour course for law enforcement, and they learn about mental health disorders and substance use, and they go around and see local resources as well as meet people in recovery from both their mental health disorders and their substance use disorders. And the idea is that it creates a team of people within law enforcement that are more comfortable and more skilled at dealing with mental health calls or substance use related calls. The initial framework for that is that you'd have a special team and they would respond to, you could request an officer that's CIT trained. The reality of how it's worked in Portland and South Portland and some surrounding towns is that all of our police officers are CIT trained. And that is because the chief has mandated that, because we run into so many calls for service with mental health and substance use nexuses is what he calls them. But essentially, even if it's a theft, but it's a theft because someone stole a natty daddy from a convenience store because they were starting to get sick from not drinking. So it's things like that. And how do you deal with that? How do you deal with the behavior, the criminal behavior, but also engage the person as a person, right? So other departments in the state have maybe 1 or 2 CIT trained officers. It's important to know that as community members and professionals, because you can always request a CIT officer or ask if they have any on staff if you're not in the Portland or South Portland area. And so, here with us in Portland, we're always going to have CIT trained officers. If they're new officers, they're trained within the first year of being an officer because the trainings are not super long. But it's a very helpful model. In fact, there are grants setting up departments across the country with their whole behavioral health team training is just that training. So we're very lucky that the whole department is trained, and in addition to that, we have a response team. And then the other thing that you're probably aware of is that there's a policing shortage in the whole country, in the state of Maine, and then especially in Portland. And there's actually a typo on this slide, but we're down about 15 to 20 officers on, depending on who's retiring, who's being hired. It's kind of always bouncing around, but we are supposed to have about 161 sworn officers, so that's not even including civilians. So we're down a significant number of people, and what that means is that the more dangerous or acute calls get sort of less dangerous calls, and they also need to clear calls quickly, so they're not able to spend an hour talking to somebody because they need to get back out on the street. What that also means is they can let us talk to somebody for an hour as a co-responder, and they can clear and go back to the street. So it's just something to be aware of when you're calling for assistance. If it's a call that is not an immediate threat, you may have to wait a little while, and that is an unfortunate side effect of not being able to keep police officers, having a bunch of police officers retire, and then just the sort of negative press around policing in this country right now. And the chief will say calls for service about 80%, I already said it, but 80% have substance use or mental health nexus. So they're connected in some way, either people's having significant psychotic symptoms and people are concerned about them and calling, or people committing crimes like theft or burglaries, things like that, to get money for their substance use, or technically engaging in substance use is currently illegal. So calls for service about people injecting drugs or drinking in public, things like that. Or even especially with how marijuana is legalized now, we're still getting a lot of calls because it's legal, yes, and you still can't smoke in public, can't drink in public. So people walking down the street smoking marijuana generate calls for service at times. We have a shelter in Portland that is an emergency shelter, meaning you don't have to register and you won't be turned away. And so we have a significant homeless population or transient population, which many of them have significant mental health or substance use issues. And we are the only shelter that does not require any sort of registration like that. So we don't turn anyone away, and that means that people are coming from other parts of the state as well as other states. People think that Portland has a lot of social services, which it does, and at the same time, it does not have as many social services as it requires to help hundreds of people. And so that also leads to, that shelter area for the police is the busiest police area in the city, even though it only accounts for, I think, 10% of the population. And so we see an increase of policing down there, but that also pulls officers from other parts of the city. And as we are down, 15 to 20 people, it's hard to do proactive police work. It's really just catching up and making sure that the safety needs are addressed. And that's the next couple slides. The focus is on safety. Officers would love to make referrals for people and get them hooked up with services, but they're really prioritizing safety and refer to us or case managers for connections. And then a lot of people don't have resources available to them because there are no, most people that I work with don't have any form of insurance or Maine care. Maine care expansion is hopefully on its way. But for right now, people are working on grant funded slots or scholarship slots, and those are hard to navigate and sometimes slow to attain. And so officers want to drop people off at Milestone for detox, but Milestone is full. Officers want to take someone to the hospital to get treatment, but just because they're at the hospital doesn't mean that they will get support for their mental health. And then I'm just reminding everyone that most police officers are good people and they want to help, but they're also kind of expected to fix all of our social shortcomings. And so they don't have a magic wand. They can't fix everything. They're really supposed to be trained in safety, but now they have to be trained in safety and trained in clinical skills and trained in de-escalation. And they're asked a lot, and then they're also not really given a whole ton of respect for the most part, or at least they don't feel that way because they're dealing with people that dislike them a lot of the time. Okay, thanks. Next slide, please. This is the slide we're probably going to spend the most time on, and actually, if you have questions on this slide, this is probably something that would help everybody, because you probably won't run into this. Maybe you'll run into it once in a professional career, maybe a bunch. It's the world I live in almost every day. Even though I focus on substance use, I also help cover mental health calls just because there's so many of them. This is, and normally I don't read a whole slide, but I'm going to read this slide just because this is verbatim the law as it's written if you look it up, and that's important. So we're talking about police protective custody, which is the ability for a police officer to take away your rights and transport you to a hospital for an evaluation. So it's called Title 34B, and this specific section is talking about police officers, and it goes like this. So if a law enforcement officer has probable cause to believe that a person may be mentally ill and that due to that condition, the person presents a threat of imminent and substantial physical harm to that person or to another person's, or if a law enforcement officer knows that a person has an advanced healthcare directive authorizing mental health treatment and the officer has probable cause to believe that that person lacks capacity, the law enforcement officer may take that person into protective custody, and if they do, must take the person into protective custody immediately for examination by a medical practitioner. Now, there's more to it, but I'm going to start with there because there's a few key things that, as someone who's not working with law enforcement all the time, you need to be aware of if you ever need to utilize protective custody or if you're concerned about somebody. So they need to have probable cause or a reason to believe that that person has mental illness or mental health issues or diagnosis. And what that means is a probable cause could be their behavior, it could be their self-report, it could be a third party, which we'll talk about a little bit more. But they have to believe that there's something going on that is a mental health diagnosis related. That's where the CIT stuff comes in handy because they're familiar with some basic diagnosis stuff. They're not able to diagnose, they're not clinicians, but they kind of know what a baseline might be. And then the other important piece is that in the state of Maine, we use protective custody solely for mental health disorders, and we differentiate for substance use disorders. I actually don't like that. However, we do not put people in protective custody for their substance use. If if you're in front of a police officer and you say, I'm going to go inject a couple grams of heroin and it might kill me, but I'm not trying to kill myself. If we think that would, you're suffering from your mental health disorder, which is an opiate use disorder, and you're at risk of killing yourself, but you're not trying to kill yourself, we don't place you into protective custody for that. In some places, in some states, they have different laws that are similar to protective custody that they could at least take you for an evaluation. So that is included even after an opiate overdose. If you refuse treatment, they will not put you in protective custody and take you to a hospital. The next important thing is that the person has to be imminent and substantial threat of physical harm to themselves or others. So imminency is supposed to be objective, but it's also subjective, right? So imminency to me usually is the next 24 hours, but for some people it's the next 12 hours, some people it's the next 3 hours. So that is a challenging one because there's no definition of that in the law. And so an example is one of my first calls as an intern. I was pretty new, so I was kind of nervous. This woman had stockpiled a month's worth of 3 medications. So she had like at least 90 pills. She had a plan the next morning, it was about 8 o'clock at night. She had a plan the next morning to drive her car out to the ocean, take all those pills, and then die as the sun came up. She thought about it. She knew she was going to do it. She was adamant she was going to do it the next morning. And I turned to the officer and I said, I think we need to take her to the hospital. And she said, I don't want to go to the hospital. And the officer said, well, I'm not going to force her to the hospital with that plan. To me, because he said, that's tomorrow, she might change her mind. And so I was new, but I would still have said, I still agree. I think she should at least get an evaluation. She had also started giving property away. She had said goodbye to her kids. She had a lot more risk factors than any protective factors I was aware of. The nice thing was eventually I was able to build a rapport with her and we took her voluntarily to the hospital. But that officer maintained that he was not going to put her into protective custody because he felt that imminency was not there because she wasn't going to do it tonight when we left, right? She was going to do it tomorrow and she could change her mind. So I like to use that example because, I'm embedded with them. Yes, I'm new and they're not sure if they can trust me yet, but, I'm saying, I'm with you. I know this law and I think it meets it. And they're saying, well, I'm the one that has to do this and I don't think it meets that law. So imminency, if you can show anything that's going to happen in the next, few hours, it's best. But if it's going to happen the next day, some officers would agree with you and some will argue with you. And the next part is substantial physical harm. So this one we get hung up a lot as well because it really has to be something that will be sort of major disfigurement or major harm or death. And so an example that I like to use is there was a gentleman walking down the middle of Portland Street with no shoes on in the middle of summer. It was 85, 90 degrees outside. The tar was very hot, probably burning his feet. He was walking in the middle of the street, so traffic's trying to go around him. And the case manager flags me down because I was down by the shelter and says like, oh, hey, so we need to go check on him. He's not taking his meds. He's walking in the street. He's trying to get hit by a car and he's burning his feet on the pavement. So I radio to the officers, say, hey, I'm going to go check on this guy. Can you have someone meet me? Officers detain him for a minute, but they pull over to the side of the road and ask him to come over. And he's willing to come over and talk with us. He's telling us that he knows he's not wearing shoes and that he knows it might hurt him, but he's okay with that. And he's also saying, I'm not trying to get hit by a car and I don't want to die, right? So the officer like, we can't do anything with this. There's no substantial physical harm. Yeah, it's imminent. He's kind of in the middle of traffic and stuff, but he's not hurting himself enough to take him to the hospital, take away his freedom. And then the next thing the case manager said was, well, he also just set a fire inside the resource room and didn't tell anyone about it. So we're like, collectively, that's what we need, right? If you're setting fires in a public space that could hurt other people, hurt yourself, you intentionally set the fire and you did not tell anyone about it and you're hoping it would burn up the building, that's the substantial physical harm. So there's sort of like buzzwords or things you can say when you're looking to get someone transported. To themselves, risk to others, and the immediacy, right? He had just done that and walked out. So that's the example I like to use, those two examples for imminency and substantial. And then we did transport him. And so this brings us to the next bullet point, which is law enforcement decision may be impacted by a third party. So in that case, a case manager's information. When formulating probable cause, law enforcement officers may rely upon information provided by a third party informant. if the officer confirms the information has reason to believe based upon the information's recent informant's recent personal observation or conversation with a person that the person may be mentally ill, and that due to that condition, the person presents as a threat of imminent and substantial physical harm to the person or other persons. So what that means is the person could be standing in front of a police officer saying, I'm not going to hurt myself, I'm not going to hurt anybody else. But 10 minutes ago, the clinician they were with, they were telling them that they want to go murder their ex-girlfriend or something. If the person is denying it to us, but the clinician explains that, yes, there is a risk, they were adamant about it, and that there's a history there. So this is where it gets more tricky too, because the officers want the person really to say what's going on. And if the person is not, they feel a little bit less inclined, or if the person's behavior is pretty calm and not threatening, they feel less inclined to transport. Once again, they're taking away their personal rights of freedom to transport them. And the police officers are personally liable when they do that. So if something went wrong, someone got hurt, or someone said that was wrong to do that, the police officer themselves can get sued personally, and basically it will end their career, as well as like financially could ruin them. So they're very cautious. They want to make sure that the bar is met. And so what happens a lot is a clinician or a provider or concerned family member will say, I know all this information and I'm concerned about them, and they said this an hour ago. And sometimes the officer says, yes, that's enough. And sometimes the officer says, well, right now they're not saying that they're going to kill themselves, and I don't feel like I have enough to transport a person. Because we'll leave the clinician not making stuff up, or the family members are not making stuff up, and the officers are trying to protect themselves and really the person that they may or may not transport. What sometimes will help that is if you are willing to write a statement for the officer, take a little bit of the decision out of their, a little justification for the decision. Like, here's what we experienced, and here's why we called the police, and this is why the person should go to the hospital. If there's liaison myself or on the team, that's what we're doing. We're not writing those supplements necessarily. We're kind of verbal justifying protective custody person. And the most third-party stuff is really just the person has and they said they were going to kill themselves or kill someone else, and it's usually listened to. There are times where the person is not presenting as dangerous enough, and so the officer will sort of contradict the person. And then the last thing up in the first says may take the person. They're required to take the person into protective custody, even meet that criteria. This also happens with elderly people, 90-year-olds who maybe have some dementia or have something where if they present, they can remove from their home to the hospital. But the protective custody could be met, but the police officer does not want to wrestle a 90-year-old person. Is into protective is dangerous, but not to the point that they worth getting into a fight with them. They may choose to wait, put the person in protective custody. Times the hospital agrees and wants to place someone, but they're not able to hold them beyond a few days. So we were weighing all of that, the law and then the efficacy of doing this when we're making a decision. And I think what happens a lot of times is officers don't explain their rationale for what they're doing. And so it's very confusing for the person who just heard someone say they wanted to die or kill someone else, and then the person is not transported. Any questions around that before I move forward? Okay. I'll give one other example of like a in between level of danger that gets, which is kind of challenging. So there's a 50-year-old man who has substance use disorder, alcohol daily, lives in the same home for 30 years. About a year ago, his wife left him because of his drinking. They've been married for 30 years. And so he is really isolated. She's still connected to him and supports him, but cannot live with him because of his drinking. He has a car duly to them and was loaning it out to people so that they'd use it in alcohol, but then the police reported it stolen. And so in the time before I met him, he had called the police saying he was suicidal and that he had a shotgun and it was loaded, and they could actually hear him shotgun in the background that he was self. So I responded to that and did not. I don't know the full details of that evening, but I was his wife about a week later, concerned about him, and I happened to be on, so I've been trying to reach out to this. So I went with the officer, and it was the same officer that was there the night that he had loaded. He still had the shotgun, and it was still loaded, and it was in the corner of the room he was in, about feet away from him, out of direct arm's reach, and he has some mobility issues from his drinking, and so we didn't remove the shotgun. Normally you would remove a weapon like that. We just acknowledged that it was there, and then told him not to go for it, and he said, I'd never go for it. I don't want to hurt anybody else. But he has passive suicidal ideation, so he's always thinking about wanting to die, but he's also afraid of dying and of pain. He really just wants his suffering to end. But he has a firearm. He's drinking daily. He's very depressed. He has a lot of red flags for depression and suicide. And he's not making any direct threats for now. He doesn't want to die tonight. He's not going to shoot himself in the head tonight. And he doesn't want to go to the hospital or go to any resources, really. So I have his wife and the officer step outside and engage with him. And we talk a little further. And I'm like, yeah, well, you're probably at like a moderate risk, but he's not at a point where we can force him to the hospital. Even though I go back out and sort of have a conference with his wife and the officer, and we're all like, we think he would be better off at a hospital, and we don't think we can force him there. And if we take him to the hospital and we force him there and he fights with us, he's probably going to get hurt. Someone else is going to get hurt. He might go for that gun and get shot. And when he sobers up, he's probably going to be able to talk his way out of the hospital. So that is one where we left him at home. It didn't feel good because you're a little worried about him, but you don't have enough to force him and take away his freedom. But he was agreeable to follow up, and he's continued to engage with me, about sort of what he wants for himself. He hasn't figured that out yet, but he hasn't killed himself yet, and he's more willing to engage because I didn't force him to go to the hospital. And so I did, and I do this conversation with a lot of people I work with. I say, we're not going to the hospital today, but if there's a day where you have to go, we're going to have to take you. And it's better if you make the decision to go yourself than wait for us to force you to the hospital. And obviously, we try to use resources other than the hospital before we get to the point of the hospital. So that's police protective custody. It's pretty black and white in the law, but it's also very gray in application. So most of you probably will never have to use that, hopefully, but if you have to, now you know how to. And this is involuntary commitment paperwork, or the blue paper. This is the medical version of protective custody, essentially. And the step that happens after you get transported with protective custody. So this is designed to be used in an emergency department setting and transport you to a psychiatric hospital like Spring Harbor, Riverview, or Dorothea Dix. And how it works is anyone can fill out the section 1 of the application. It can be a family member, a clinician, someone that knows the person is really the only requirement. But they don't have to be licensed. They don't have to be a clinician. And then section 2 is an examination. So somebody that has one of the licenses listed there under that first blank space is required to fill that section out. So and you'll notice that LCSW or LCPC is not in that section. It has to be a medical provider. So if I try to fill that out, it is invalid, and I cannot legally fill that out. And you can fill out A, B, or C. It doesn't have to be all of those portions, but those are reasoning, your rationale for why this person needs to go to a hospital. And C is one that sort of differs or is harder to prove with protective custody. A and B are basically protective custody laws. C is more the person is at risk of getting hurt or harming themselves due to not taking care of themselves or being struggling from their mental health issues so significantly that they're going to be at risk. And so that is much easier for a doctor or a medical examiner to justify and explain than a police officer, right? And the one that we run into for protective custody versus this a lot of times is people not eating. So people haven't been eating for weeks and they're losing a bunch of weight. And essentially the perspective of a law enforcement officer is we have people that are connected to you and checking on you. And now we know that you're on our police radar, so probably our behavioral health team is going to check on you. The likelihood that you will die from not eating before an intervention will happen is very low, and it's not imminent enough for protective custody. For this, people have been blue papered for not eating for extended periods of time. Usually there's some other characteristics and history behind that as well, but a doctor or a nurse who knows their patient can justify filling that out. And then the last part is a judge signs this. So this is a legal piece of paper. It works like a warrant. Once it's signed, the person has to go to the hospital, and the police are required to do that transport if they're the person listed for that transport. What happens in the community in practice a lot is people will fill out section 1 and 2, and there will be no judge's signature, and they will say, well, I have a blue paper filled out, so you can take them to the hospital now because here's why. And that really falls under third-party information for protective custody because it's, that's a lot of good information. But a police officer can disagree with your interpretation of 1 and 2 and not put the person in protective custody and transport them. Once this is signed by a judge, all bets are off in terms of denying it. They're just doing the order of the judge, right? And the confusing part about this is that this is designed to be from an inpatient setting to another, or from an ED setting to an inpatient setting. The reality of its application on a very few cases, mostly in Portland, is that there are some of the assertive community treatment teams or ACT teams, which have very acute people, often with co-occurring disorders. Their teams have nurse practitioners on them. They, at times, will fill out one of these blue papers, and instead of saying a psychiatric hospital, they will put one of our local hospitals, usually Maine Medical Center. And although it's not technically really supposed to work that way, the judges are signing those. And so once that happens, once again, the police officer has to transport them because it's like a warrant. And what we run into, what's confusing is it's happened like that for so long in Portland that police officers are used to that is how it works. And so if they can't put someone in protective custody, they might turn to the provider or the doctor and say, well, just blue paper them. And the doctor says, well, blue paper is supposed to be from the hospital to an inpatient setting. I can't blue paper them. And they're both right about that because they both had different experiences. So as this is written, you'll probably never use one unless you work in an emergency department or if you work on an ACT team. I know that the ACT teams have been using them successfully to really get people into the hospital who otherwise they couldn't do, and they're in that gray area of not meeting protective custody, but we're very concerned about them. And so the last thing that I'll just touch on quickly was that other thing talking about advanced directive in protective custody. It's called a green paper. It's once again, it's connected to an ACT team, and it comes out of the psych hospitals, and it's basically circumvents all this. If somebody doesn't engage in their treatment, the ACT team can reactivate a green paper, and it works the same way. A judge signs it. It's like a warrant. They have to be transported back to treatment. So with a blue paper or protective custody, often we have to wait for people to get very sick and get dangerous to themselves or others, and then we can do something. A green paper says you history to get so bad that you're dangerous to yourself or others before we treat you again. So we're going to activate this thing called a progressive treatment plan or a green paper, and we're going to return you to the hospital before you get to a 10. We can get you at a 3 and keep you safe. So that's the difference between those three things and the requirements. Once again, it's an important thing to be aware of, but most people will not ever fill one out. I've only seen 2 green papers in 4.5 years. They were both in the same week, oddly enough. And I've probably done, 25, 30 blue papers from the community, which is, once again, not their main purpose, but it is something that they utilize as a tool. So next slide, please. All right. So we're going to transition to substance use disorders. So you've probably heard this before. We can't arrest our way out of this problem. You'll hear the drug war was a failure. That is great. And the drug war is still happening. And police officers still get frustrated and try to arrest the problem away. So even in Portland, where we're really, the officers are told not to arrest people for substance use, they're told to arrest people for drug trafficking. But if it's like an overdose or you know, they're stopped for something else and they have a little bit of substance on them that is not, it's clearly for personal use, you know, they might confiscate it and throw it out, but they're really not supposed to arrest people for possession, simple possession like that. The idea being that putting them in jail for an overdose or for simple possession puts them at higher risk, especially with opioids, of death when they return to the community from jail. And so that puts officers in a weird spot because they're not really sure exactly what to do. Now that my position exists, it's helpful for them in Portland because they can say, well, I don't have to deal with this. I'll just have you go talk to Oliver. And so the problem being whether we can't arrest our way out of the problem is we're so shortchanged on resources in the community right now that eventually the same person will come up over and over again and officers will like, I don't know what else to do. I'm gonna put them in jail for a few days. Or I feel like I need to do something, so I'll write them a summons, which is a ticket, which means they don't go to jail directly, but they still have to go to court. If they're working, it really interrupts their work schedule. They could maybe go to jail. They could maybe have fines that they can't pay, that they then get warrants for failure to pay a fine, then they go to jail. We actually just had somebody that I've worked with for about 2 years who was doing pretty well. He was in treatment, got housed. He was homeless for a long time, but he went to jail on a warrant because he didn't show up for probation for 2 months, which, you know, is unfortunate. But he lost his tolerance, he lost his treatment, came out and overdosed and died last week because of something unrelated to his substance use or unrelated to really criminal activity. He just didn't show up for probation, and he'd been on probation for 2 years. So he knew he needed to do it. But jail is an extremely high risk place for people. They either make connections with other people that are using and go, you know, when they get released, they go hook up with people, or they have no tolerance, they get out, they use what they're used to using, and they overdose and often die. So I like to use the chronic relapsing brain disease or the medical model. I think it's easier for people to swallow, and it's simple enough as well. And I like to use the word relapsing. There's some movement about not using the word relapse because it maybe perpetuates some stigma. But I think if we talk about relapse for what the medical term is, which is a return of symptoms that require an intervention, then we can talk about relapse in a healthy way, because all chronic conditions have relapses to them. That is part of why they are chronic. That being said, when most people say relapse, they think of drugs and alcohol. So we want to refocus if we're going to use a medical model, which is, our country likes medicine, so we like to use brain. Most people are primed for their addiction, and then the drugs that are being available to them are much more potent than they used to be, and they're just changing. So primarily opioid overdose in Portland and in southern Maine is with street drugs. So I've seen 2 cases of pill overdoses in 2+ years. So very rare compared to how it was a few years ago. I will say the northern half of the state, I was up north of Bangor the other day, and they are still seeing a significant amount of pills. They still see a significant amount of heroin and less fentanyl as of now, although it's still up there. We are seeing almost all fentanyl in Portland and Cumberland County. In fact, it's actually difficult to find heroin, and most of the people I work with would prefer to be using heroin. It just, the way it affects them is better. They know how to use it a little safer, and they don't have to use as much of it. So that's changing, as well as there's a lot more stimulants on the streets in the last year. So crack, cocaine, methamphetamines have been increasing. And what we see a lot of times is people will start getting methadone or Suboxone treatment, and they will start using stimulants because they're not getting sick anymore, but they're not necessarily getting the boost in their mood and the euphoria, and that's part of what they're seeking as well. So the stimulants will do that because they're affecting different parts of the brain. And so police are still trying to interdict drugs in Portland. They're just trying to target the people preying, especially on our homeless population. There are people that will drive in just to unload drugs to people down at the homeless shelters and then leave. So they're really trying to target those people, not the people that are down there and are sort of disenfranchised. And you know, if they find somebody that wants help, the police department is trying to utilize referrals over arrests, their primary referral is just going to be me or giving someone a little card with my number on it. I prefer to meet people sort of in the moment if we can, so that's the co-responder model. If you're face-to-face, they'll tend to at least talk with you, even if they're not sure what you're about. In fact, one of the guys I was recently working with thought I was a detective or a DEA agent for the first 2 times he met with me, until he really believed that I was not, and that I was all about figuring out what he wanted to do. So people are cautious, and if I'm just a stranger on the end of the phone line, they're probably not gonna want to talk to me. And I can also let the officers leave, which is helpful, because they'll yelp a police officer about pretty much anything to just get them to leave them alone. And I think most people do that if there's a person of authority kind of daunting over you. But and then compassion over punishment. I've seen some really fantastic conversations between police officers and people that they've worked with for years or that they care about. And that's really the approach they want to take. They get frustrated and then they kind of revert back to solution focus where they arrest people. But they really just want to spread compassion and help people, which is not something you think about when you think of policing. At least I didn't before I started there. And the most common response for police and for me, and for really the most common response we can all engage in, no matter the setting, is just a conversation, right? And not advice giving and not dictating what the person does, but just treating the person like a person and like a human, and having some compassion and really hearing what they're saying. And so there's been a couple cases where people have had that conversation with a police officer, or a couple police officers will say, if I had to arrest someone for any reason, I use that time transporting them to jail to just talk about what's going on. We don't want to lecture them necessarily, but we would like to engage with them and see if they want to do something different. And if they do, they will try to refer that person to me. And sometimes jail is useful because I can go into the jail, so I'm clear to go right into the pods. I can go find someone and say, hey, what's the plan for getting out of here? What do you want to do? And I'll follow that plan, whatever they want to do. I'll do whatever I can to make it happen. But it's mostly about connection and conversation, and that's a framework for most of the work that I see in the community that's being successful, is engagement and connection with people, and less about abstinence or formalized treatment. And that's where the successes come, is that engagement, because then when people are ready, they have someone that they can turn to. And that doesn't have to be a counselor or a case manager. That can be a primary care doctor. That could be a family member. You just never know who that person is going to be and when it's going to happen. And then the difference in how police respond is varied very widely throughout the state. Your county sheriff's offices and your state police and your local departments are all going to respond slightly different to substance use. It technically is still illegal, and so some departments carry naloxone, some departments refuse to carry naloxone. Some will arrest you for possession of heroin, and some will give you a summons, and some will say, hey, let's have a conversation. I'm going to take your drugs and destroy them, but let's have a conversation about what else you want for yourself. So in Southern Maine, most of the departments are more of that approach of, we're going to take away your substance because we can't leave it with you, because we have to uphold the law, and that's what the law says. But they will try to engage you in a conversation, and sometimes we'll give you a summons. So it really depends where you are, and there are some places where they're still arresting everybody, and they give high fives and handshakes when they get a gram of heroin, and it's a big drug bust. That's not very helpful, and I think we're trying to move towards the whole state being more of a harm reduction and engagement approach, but we're not there yet. There's still the idea that people who are using street drugs are bad or dirty or morally corrupt, things like that. It's sort of some old style of thinking. And then also officers are burnt out because they see the worst day ever of everybody every day. So you don't necessarily see the successes, and that's actually the number one thing that officers ask me about is, do you have any good stories? Do you have anyone that's made it out of here or is in recovery? And so that's some of the value of CIT as well, is seeing success, seeing recovery. We have a couple of police officers that are in recovery, and they're openly in recovery with their peers and sometimes they'll even say to people on the street that they're in recovery, because they're like, we need to normalize this. We need to get rid of the stigma. It's okay. And they're leaders in the department. I'm proud of them for doing that. This is a little confusing bullet point. So there's no good Samaritan law for opioid overdose. And what that means is there is a medical Good Samaritan law. So if somebody is dying in front of you, you can revive them with naloxone or give them chest compressions, and no one will hold you liable for trying to save someone's life. What it does mean is that there's no protection during an overdose if you have drugs on you, if you have a warrant, if you sold the drugs to the person. And so the practical application of that is that people don't call 911 when their friends or their people that they're with are overdosing. They usually try to do home remedies like sticking ice down your pants or injecting you with other drugs, lots of other things that they're putting you in the bathtub. And they waste a lot of time. And I read the fatal overdoses for Portland, and a lot of them happen because people didn't call 911 in time. And by the time they decide, well, we should just dump all the drugs, call 911, the person is either dead or close to dead. So something that we've tried to pass a couple times, I think 3 times in the state, is a Good Samaritan law that would protect people during overdose, and it has not made it through 3 times now. I think that would be it's a challenging sell, especially for law enforcement, because it also ignores warrants, and that's something that they really will still pick you up for. And there's some idea that it somehow protects drug dealers because they can call a known overdose and then be protected from selling the drugs. But my response to that is, it more important to catch the drug dealer or keep someone alive? People are literally dying because they're afraid to call for help. And so we probably only get about like a third of overdose calls for fire and EMS in Portland. And most people will use naloxone on each other and monitor each other and have gotten quite good at keeping each other safe and alive. Or we'll drive or find a friend, and that friend will drive them to the hospital. And then police are just overwhelmed in general right now with calls for service. So sometimes they won't spend a super long time with someone with substance use disorders. And they feel like people don't necessarily want that help. So they are going to just make sure you're not going to die right now, and then they're going to let you be on your way. That can be kind of scary if you're a third party and you're calling about somebody that's really intoxicated and you're worried about them. Until the person is unconscious, they can refuse treatment and refuse services. So if someone walks up and is really high but is not overdosing, they can say, we're not going to talk to the police or the fire department, and the police will let them go. So that's just something to be aware of. They believe in autonomy until you meet protective custody or until you're unconscious. So you want to go to the next slide, please? Thank you. Okay, so what do you do during a crisis? So I work with police every day. I work with fire every day, and still, when I have to call for something, if I'm not using the radio, if I have to call, like in my second job at crisis unit, if someone has a medical emergency, it's still stressful, right? I'm super comfortable, and yet I'm still stressed out. So being aware that you're going to be amped up, especially if someone is potentially dying right in front of you. So the good thing about 911 is if you call 911 and not non-emergency, they will ask you specific questions, and you don't necessarily really have to think a lot. You just answer the questions, which is also kind of frustrating because you want to tell them the whole story, but you need to go in order of the questions that they are giving you, because they are triaging what's going, and they're sending help immediately once they know where you are, but they need to send the right amount of help. And they're going to do that with their questions. They're required to use the questions. They can't skip around. So it's just good to be aware of. The non-emergency number is great for anything that is not an emergency, right? So anything that's not immediate safety or medical risk, you can call the non-emergency number. So for mental health stuff, a lot of times if someone isn't actively about to kill themselves, but you're concerned about their psychosis or their behavior, non-emergency is good because they'll put it out when it's appropriate. That might mean it might take an hour for them to go check on somebody, but if the person's not at harm to themselves, that's okay. I use non-emergency number if I don't have my police radio for probably 95% of anything that I am doing. I've even called in overdoses on non-emergency, but the only difference, the same person can answer both non-emergency and emergency phone calls. The difference is if they're both ringing at the same time, they'll take the 911 call over the non-emergency call. And that, once again, that's how it works in Portland. We have a giant regional dispatch that does Portland and South Portland. It's a big room. Some more rural departments will have one person doing it all. So that might not be as big of an issue, although once again, I think that is a standard for dispatchers. If there's a 911 call and a non-emergency, you always answer the 911 call, and they all have that protocol they have to follow. So being aware of that and using the right number is always useful. And then listing objective observable facts. We run into this a lot where people try to interpret what's going on, both for 911 and both in non-emergency, and it's not very helpful because the dispatcher will put out the narrative if they don't have facts. So it could be, it could be a narrative of what you think is happening, but that's so far from what's actually going on with the person. So if you describe behavior, or if you know they've taken something, that's really helpful because it helps everyone on scene figure out what's going on and respond appropriately. And that's easy to think of, but also sometimes we get wrapped up in the content of things, and we tell a narrative story rather than kind of what's going on objectively and observable. And I think I'm going to talk about this on the next slide as well, but if you're not with the person, so a lot of times we have like check the well-beings on somebody. If you or somebody that knows the person can meet the officers, that is really helpful. It's helpful to have somebody on scene that knows a lot about the person, or that will engage with the person, or the person will engage with. That's not always possible, but it is challenging at times. We have people call us because it's the end of the day and they're concerned about somebody, and they're going home at 4:30 and they call at 4:15 to do a check the well-being, and then they go home, and then we check on the person at 5, and we don't really have any further information. No one is meeting us there. So if you can meet the people, tell dispatch you'll meet them, or at least give a statement if they need it. And then substance use as well is helpful if you're an expert on the person to provide information, or at least give a callback number at the very least. And they're focused on safety, right? So any weapons or history of violence or anything safety-wise is important to know. It's better. I know people are probably anxious about that because a lot of things in the news talk about police officers killing people and shooting people. They're better prepared and will make better decisions if they know what the risks are. It's when things surprise them and they go into that escalated place, which they're trained to try not to go, but we're all human. And if somebody is pulling a weapon on us that we're not expecting, that will heighten us. And they also won't confront somebody with a weapon for the most part. They will try to talk them out. An example of that is this woman I worked with for a long time, used to get really drunk, call dispatch, really kind of just talking to them, but she called saying she had a gun and that she was going to kill herself or kill anyone that entered the apartment. So I've been to that house, 40 times. She talked about a gun. She never had a gun. She said her son had the gun, so she didn't have access to it. So I always, took that as truth. It turns out that was the truth, but because she was intoxicated and said she had a gun, her apartment is now surrounded by about 4 officers. Some have their handguns out, but some of them have like rifles out, and they are setting up a perimeter for a standoff because they don't want to shoot her, but they also don't want her shooting other people. And eventually I was able to call into dispatch and conference call with her and talk her out of the building, and she didn't have a gun. But they're going to set up that perimeter if they believe there's a gun involved. If there's knives involved, they're going to also do that. Although with knives, I've seen times where they've had guns out, and I've seen times where they put themselves at risk to tackle the person and wrestle the knife away from them, even though some of them could have easily gotten stabbed in the stomach. So they don't want to kill anyone, and they want to keep everybody safe, but they're also going to bump that up to the highest level of safety that they possibly need for safety of themselves and others, because they all want to go home at night as well. And I already talked about the strict set of questions. Okay, so next slide, we'll talk about on scene with first responders. I believe I mentioned this, but I will talk about it again because it's actually sort of a not super common knowledge, and it's really important. So there's this thing called priority of life protocols. And that means that, and I believe almost every municipality and law enforcement agency in the state of Maine has adopted this. I know that in Portland area they have. And what it is they found through research that people who are at risk of killing themselves are more likely to be killed by police officers than helped if the police officers forced confrontation. What that means in practice is if somebody is at risk of killing themselves and they are alone in a home or alone in an area where everyone else can be removed, the police will not force confrontation. So if you're in your apartment and you called someone and said you're suicidal and you're going to kill yourself, they're not going to kick your door in and wrestle you, take you to the hospital, because the research says that there's likelihood that you will essentially get shot by the police more so than saved and taken to the hospital. That can be really frustrating for practitioners because even if that door is unlocked, which I've run into, the police will say, we can't lawfully enter this apartment. Yes, he might want to kill himself, but he's by himself. We have no medical reason to go in there. So if somebody is dying or at risk of dying from a medical reason, that does not fit this protocol, right? So if they're overdosing, if there's reason to believe they could be dying from diabetic complications or seizures or things like that, they will make entry. Usually they'll use a fire. The fire side usually has a key or will make entry with them. But they're not going to do that for somebody that's suicidal, once again, because the priority of life is that we want to do as little harm as possible, and there's a more risk in kicking a door and then leaving the person by themselves. Now, if someone else is in there, that gets trickier, and they will likely make entry to make sure the other person is not at risk. And that's what you see a lot of the times with, people. I think there was a man last year in his garage with a gun, and his family was there. They got the family out, and then the confrontation ended up with the man dying. So they will make confrontation if other people or other people's safety are involved. What that also means is that they might not make contact with somebody, and they might just leave, clear out the call, and you don't know what happened. So that can be frustrating for people concerned about people. Is, well, I sent the police to check on you, and I don't know, I didn't hear anything, and I think probably you're fine. But you find out that the police knocked, no one answered, and then they cleared, right? They might put an attempt to locate out if there's enough threat that the person is like actively out there doing something. But if there's, someone said they're suicidal and thinking about ending their life, and we don't make contact, that's probably where that ends for today, unless new information comes in. So that's something that's sort of behind the scenes and not a lot of people are aware of, at least in my experience. And it's good to know, because if you're concerned about someone, they may not actually see somebody to be assessed, at least in the greater Portland area, but I believe in most of the state. And we've talked about this a bunch, so I'm not going to talk about it too much longer, but officers respect autonomy and people's rights, right? So if I take you into protective custody, the police do, because I can't, I'm taking away your freedom, which is a basic right that you have, and you haven't committed any crime. So I'm not going to do that lightly. I'm going to do that if it is necessary to keep you safe and to keep others safe. And I'm going to use my words as a tool to get you to the hospital without doing that, because that is better for everybody. That also might mean that you can leave and no one will notify us and we won't know what's going on. Whereas if I put you in protective custody, they're supposed to notify us. They will do that about 50% of the time. Do you have a question? Can you mute your microphone?
Their phones to mute them.
Okay. Thank you. Unless you have a question, and then unmute it. But all right. So, and then just as most of you know, having mental health disorders, not against the law and often not dangerous. In fact, people are more likely to be the victim of violence than perpetrate it. And then, we get called for mental health calls all the time, especially down the old port or tourist people that are not used to experiencing people with significant mental health issues. And for the most part, those interactions are just, how are you doing? Okay, do you want anything? Do you need anything? And if they don't need anything, they're going about their day. They might even be able to stay right where they are. I mean, we are about people being safe and engaging with us. And if they are just making people uncomfortable, we'll let them know that, you're yelling at yourself is making people uncomfortable. What can we do to help you with that? And sometimes we'll help take them somewhere else in the city if that's where they want to go. But if there's, sitting down in the old port, they have the right to be there. So we're not going to harass them out of there. And then we have a team of people, myself and 2 other people, that will respond in the moment. And we will sit with somebody if they're having a hard day, and the officers can leave and they can just talk to us and we can figure out referrals and options and do what needs to be done to minimize the damage for the person and for the community. So you can always request a liaison, right? So if you're calling dispatch and it's a mental health or substance use call, you can ask for us. South Portland has a liaison. A couple of surrounding communities have them. Up north, a couple places have substance use related liaisons. And if you meet officers at the door, like I was saying earlier, or engage with them, a lot of times doctors' offices, that's really helpful. Tell them what your goal is. Is it to go to the hospital? They'll try to make that happen. If you're telling them that's what you want, they're going to try to make it happen because they believe you. It's just whether or not they can do it legally. And they're doing the best that they can with the tools that they have. It's important to know that officers can be dishonest with people. For most of us, we have an ethical code of some kind that doesn't allow us to lie to people, or honesty is a core value and ethic, they can use manipulation essentially to get people to do things that they want. Usually that means they can lie to them to get them to go to the hospital voluntarily and then deal with it there. So that that can be challenging sometimes too, working that like interprofessional relationship, right? I'm never going to lie to the client. The officer might lie to them to get them to go to the hospital. You know, if the officer tries to include me in that lie, I'm not going to be part of that. I will probably redirect that conversation because my code of ethics and my values say that I don't lie to the clients that I'm working with. But the officer's usually making, you know, engaging in dishonesties to preserve safety, because that is more important to them than the honesty. So it's good to be aware of, because you might be sitting with a police officer and they're doing something, you're like, oh, this is not cool. But that's how they operate, and it is so they don't have to wrestle someone, put them in handcuffs, and get them to the hospital. And if you have any documentation or a face sheet or things that talk about the person's diagnosis or information, if you can have that ready or give that to them, especially if they're going to the hospital, they'll transport that up and hand that right over to the medical staff and the psychiatric staff. All right, next slide, please. All right, so overdose. In the city of Portland, police and fire respond to all overdose calls. That is both mental health overdose in the sense that someone is trying to kill themselves, and accidental overdose. The police are there for safety, really, and to help clear any real needles or anything that could be dangerous for the fire department. We already talked about no good Samaritan law a whole bunch, so I'm not going to reiterate that. If you are at an overdose or see one or suspect one, just, you know, most of you probably work in some sort of agency. Your protocol is probably call 911. If you're in the community, call 911. We as a community are responsible for helping others and keeping everybody safe. What we run into a lot in Portland, once again, because of tourism, as well as you know, people that have no place to be, homeless population, people are concerned about a person due to their use, but are not sure if the person's overdosing. Maybe they're lying down on the sidewalk, or maybe they're walking with their eyes closed. You can call the non-emergency line for that if you want, or 911, either way. And just once again, report the observable behaviors, and they'll go check on them. Half the time the person says, I'm fine, I was just sleeping. But there are those times that the person would be dead if you know, a passerby had just said, I'm worried about this person. And if you're comfortable, you know, in my personal life and in professional, if I see someone that doesn't look right, I will go check on them myself. If you don't want to touch the person, you can yell and try to get their attention. Or you can try a sternum rub, which is making a fist and using your knuckles and raking the sternum, right? Some people don't want to do that, especially if you're a man and there's a passed out woman. You may be uncomfortable doing that. I totally understand that. But if you're comfortable about someone being dead, it's worth doing, because it's painful enough that they will wake up if they're not overdosing. You know, so that's your personal discretion. Know that it's okay to do that. And then the other thing about overdose is that it's not a painful or negative experience on its own. It's really the reversal that is traumatic and frustrating and scary. They're going from this place of euphoria, or at least comfort, where they are overdosing, and they're kind of going on to unconsciousness, and they're being thrust back into consciousness, often surrounded by maybe 8 or 10 people. In Portland, usually there's 2 police officers, a sergeant, and about 5 to 6 medical staff from the fire department, and they're usually all surrounding you. So you're on the ground, they're towering over you. And you've probably gotten more Narcan or naloxone than you need, so you're in withdrawals, you're sick, and your trauma history is triggered, and you're in fight, flight, or freeze mode, right? And so you're usually rude to people, you're usually confused, which is normal. And so people lose sight of that. They say, oh, this person is being really grumpy and agitated, and they're mad that we ruined their high. Well, they might be mad that you ruined their high, but they're more so just scared, and they need someone to treat them like a person and engage with them. And I talked to the fire department a lot about this. The medical crisis is over when the person is talking to you, right? With an opioid overdose, anyway. And so it's a mental health crisis at that point. They're in crisis. They almost just died. They're realizing they almost just died. They're also scared that they might get arrested, although most people don't get arrested, right? So, you know, we have to remember that the use and the overdose itself is not as intimidating or negative as coming back from the overdose, because it's triggering a lot of stuff that was being negated by the use, and they're not feeling anything from the substance that they use for the most part. And then it's important to remember that the naloxone will wear off 30 to 90 minutes later. And so we always want people to go to the hospital. However, they are not required to go to the hospital by law, and we can't force them to the hospital with protective custody or anything. And so we explain the risks. Some people say, yeah, roll their eyes and walk off, and some people are willing to go. As part of my job, I go with them because it's a really scary experience anyway, and then to go to the hospital by yourself and be alone after this intense thing is often really terrifying, and just sitting alone with your thoughts. That often, especially if people are in recovery and they use an overdose, there's a lot of shame and emotions to process with the person, and the hospital staff doesn't really have time or capabilities to do that. And sometimes they don't even think about like simple things like, is there anyone you need to call, or things like that. So I'll go with them and we'll make calls if people need phone calls. I'll sit with them and talk. It doesn't even have to be about their substance use. It's just spending time with them, because at the end of the day, this is really all about engagement and trying to engage with people around safety and wellness. All right, so next slide. So I'm not going to spend too much time on this because you can find this on the internet or anywhere, or many of you might be familiar with it, but these are just the basic signs of an opioid overdose, which is the most common thing that we will see for overdose symptoms. The data from the police department went from, I think it was like less than 20 like 5 years ago to we have about 30 a month at this point. So we went from like a non-existent data point to a giant chart that has about a 30% growth rate on it. Although it has leveled off a little bit. But they're opioid overdoses primarily. Sometimes there are other substances. The thing to be aware of is an opioid overdose and a benzodiazepine overdose will look very similar to each other. The difference is opioids have pinpoint pupils if someone is using opioids. That's not necessarily a sign of overdose itself, but it is a sign of opioid use. And so what we see a lot of times is people require lots of Narcan or naloxone, and we find out that they've had both opioids and benzos on board, and those look similar, and they don't come back as quickly when both of those are on board. And the other thing is, I read a lot of reports where someone just thought their loved one was snoring really loudly, which is challenging if the person does snore. But this term that we call the death rattle or gurgling sound, once you hear it, you will probably never forget it. It's more of a chest snore and gurgle than a nasal or sinus one. If somebody that doesn't snore is doing that, I would just check on them. And if they are overdosing, I always recommend calling 911, calling emergency services, and having them go to the hospital. But if you're not going to do that, don't leave them alone and stay with them. So you can look at those signs if you want on your own time. Next slide, please. So, one of the goals is talk about the mental health system. And so these are sort of the levels of care, right? So for mental health, outpatient, just like primary care settings is really the most common for basic mental health needs. So depression, anxiety, we see our primary care doctor, they give us an antidepressant, or some give you stimulants or anti-anxiety meds. That's really common, and I think that is a good model for most people. It also is a challenging model because some of the doctors are not super comfortable necessarily prescribing what they're prescribing. And the first line of defense really for most things that we have in our culture are medications. And medications are good, except that they're not a magic wand, right? We need medication and behavioral change for really almost everything. And there's a lot of data for mental health symptoms and physical health symptoms that behavioral change, like just basic things like sleep, diet, and exercise, are as effective as a medication. Antidepressants are not really effective long term. Same with even antipsychotics and things. And so outpatient is great, primary care is great, and they're, in Southern Maine, you've got big systems like Maine Medical Partners and Mercy Primary Care and Intermed and Martins Point, and those are all really good, basically groups of providers. So you really can't go wrong, but you'd be surprised how many people, especially with mental health symptoms as well as substance use disorders, don't even have primary care, haven't had a physical in 5-10 years. So that's something that gets overlooked a lot as well. And so I always try to steer people towards at least having a primary care doctor, because if all else fails, they can prescribe medications, they can do health screenings and things like that. Then we also have sort of the ACT teams, the assertive community treatment teams. That's a case manager, a counselor, and a psychiatrist most often, and they are really targeting people that need a higher level of care but are going to be in the community. So they're not inpatient or residential even, they're just teams of people that are specialized and equipped to deal with significant mental health issues. There are 4 currently in the Portland area, which is very beneficial. You know, there's one that focuses on co-occurring disorders of mental health and substance use, and so depending on the person's needs and who they like to work with and location, there's lots of options in Portland. I'm not as familiar with the ACT teams around the state. However, they're pretty restrictive because they require some Maine care options and things like that. So with the current status of Maine care or Medicaid expansion, a lot of those teams are pretty much at capacity because it's more so people don't have the Medicaid than they don't have capacity themselves. Those are also the teams that are often doing the community-based blue papering and things like that. So what we like about them in Portland is they're really good at working with law enforcement and collaborating with us. And when they're calling us to transport people, we know that something is off and there probably is a safety issue. Crisis stabilization units are another thing that is, I think, flies under the radar for mental health and substance use. So in Portland, we have one in South Portland. It's connected to our countywide crisis team. And what crisis units really are for adults are a place to get your basic needs met. So your safety is improved, your health stuff in terms of basic dietary needs, sleep, things like that. And you can focus on just yourself. You don't have to worry about work if you're working, family stuff. And people mostly stay 3 to 7 days, and they show incredible improvement most often. And it enables us to stabilize people so they can get outpatient providers, right? So the primary referrals from a crisis unit are to primary care and outpatient providers, sometimes ACT teams or higher level of care teams. But for the most part, people just need their basic needs met for a little while because they've negated them, because that's what we all do, right? We get so busy that the first things to go are diet, some exercise, and sleep. So, and if you have a significant mental health issue like psychosis or bipolar, not sleeping is not good for you. It's not good for any of us, but however, it'll exacerbate all those symptoms. And then there's the most used resources, the hospitals, right? So when all else fails, people end up going to the hospital, or if they don't have any of these other resources available to them, people will often walk themselves into a hospital because they don't know what else to do. So our system is overloaded at all levels, really, and people that don't have insurance might not be able to get outpatient providers or go to an ACT team. They can access a CSU or the crisis team without insurance, and a lot of the other resources, we have grant funds or systems of care where someone can get free care. They just maybe don't know about that. But the hospitals really are where people struggle. There's long wait times and things like that. It's because a lot of people don't need to be at the hospital, but the system of care is not set up currently to really help people manage themselves in the community, especially if they're homeless. It's very hard to do anything if you don't know, if your safety is not guaranteed and you're not housed, right? And staying in the shelter is very challenging. You're about 2 inches from the person next to you. You're on a mat most of the time on the floor. And so it's hard to get any of this higher level stuff done. And so people just go to the hospital, get a little bit of rest, maybe get some treatment, but then they're back out. And then inpatient, very few people go inpatient, but we do have psychiatric hospitals that get utilized. So that's sort of just like the level of care. Most people are going to be outpatient, but don't forget you can use your crisis stabilization units in hospitals. Probably should be avoided. I try to avoid going to the hospital with people whenever it makes sense. So next slide, please. All right, so similar to mental health, most everyone is underinsured or uninsured. And so I have maybe 10% of the people I work with and encounter, both homeless and housed, have insurance, or if they do have insurance, it doesn't cover really anything that they want to go to. They're often either homeless or basically homeless, right? They're living with friends or living in this unsafe situation where other people are using. They're using multiple substances, and that might be unintentionally. Fentanyl is being mixed in with a lot of different things. A lot of these synthetic drugs, you're not sure what you're taking, even if you think it's one thing, it's another. And so that complicates things like detox or withdrawals. There's a lot of designer drugs on the internet that people are ordering, and their detoxes can cause delirium, psychotic symptoms, things like that. And you maybe have seizures. Seizures are quite common lately, and people are not taking things that necessarily should cause a seizure, and then they're having withdrawal seizures. So we just don't know what people are taking because of the amount of synthetic things and the amount of access to things through the internet and through the mail. The medical system is pushing people towards primary care, which, you know, I talked about a little bit, especially for Suboxone. That's really like an outpatient model for that, you know, some agencies are pushing across the state. That works if you have, once again, if you're housed and you have stability, it's really great. If you don't have that, you may divert your Suboxone to pay for other things, which could be other drugs, but it could be basic needs. And so I like that as a model. I also think we need to be careful of calling it the only solution or the solution we need for everybody, because going to a primary care doctor once a week or once a month is not necessarily going to change the rest of your life, and it's not really going to necessarily help improve your life. And they're likely going to kick you out when you start using other substances because they're not necessarily trained in a harm reduction model. So that being said, MAT or medication assisted treatment is great, and it's also not a magic wand, right? It's not take this pill and everything's great. So we use it as a tool, right? And then that's my perspective on all medications. Medications are a tool, they're not the solution. So if we approach like that, I think we're better off as a treatment community as well as a sort of community in general. And then so often people that inject drugs are admitted to the hospital for infections and upon release have really minimal options to continue treatment. So you get a blood or a heart infection from injecting a bacterial infection, they need to give you IV antibiotics. They keep you in the hospital and they might detox you or they might put you on methadone, but then there's not necessarily a system of care that exists to keep you on that methadone once you are released from the hospital, or you break your leg and you have surgery and you get put on Dilaudid, and then you don't have a system of care in place to either detox you from that or continue medication-assisted treatment. So often it's unintentional harm, but it still happens quite frequently that people are put into a weird system of care that doesn't necessarily have the resources to continue treating them. So next slide. All right, so rehab is it's like a buzzword. So it's a generic term. It's not licensed and it's not regulated in this state or really any of the states. There's been a lot of problems with places like Florida where people are opening places that are really not providing any sort of treatment. And then at the same time, you'll hear a lot of people say, I want to go to rehab, I want treatment. What they mean is they really want to go to residential placement. They can get away from the environment they're in. They can move towards building a recovery community for themselves. So that's as simple as that. We have a handful of places that don't require insurance and they're very good in the whole state. And then there's some other that are private pay, which most of the people I work with can't afford anyway. That being said, because there's minimal resources, you could exhaust all of the resources in a single day. In fact, I spent 2 hours with someone who called all the options that were available to that person. And I was like, I must have done something wrong. So I called the recovery center on Forest Avenue. I was like, what are some other options for people? And, at the time, Steve Cortrell was like, you just called all of them. So that is a challenge of the system of care, is you have someone that's very ready, very willing to engage, and they just don't have an option. They might wait 2 weeks, they might wait 2 months, and they might die waiting for treatment. And then sober housing versus recovery housing. We have a strong sober housing community in Southern Maine and actually across the state. However, most of them do not allow medication-assisted treatment, so they're not what we would call recovery housing. Kind of differentiate a little bit between that. So what we need is places where people can be on medication-assisted treatment. And while that is growing, it is hard to make happen. And then also, there's been some pushback of sober housing in communities across Maine because people don't want them in their communities. And so there's still a lot of stigma around that. And there's an idea that crime will follow sober housing and a bunch of those other things. So we as a community, of the state of Maine need to embrace recovery housing and sober housing and make paths for those people in the community, because if people don't have their needs of having housing met, they're likely not going to be able to maintain their recovery. And then once again, people's basic needs in general, right? Food, shelter, and then working your way up, like belonging, relationships. most of what happens in recovery is at the top of Maslow's hierarchy, if you're familiar with that. And most of where people are in active use is the bottom, and we need to build them up to the top. And yet we expect them to be at the top, right from day one. So next slide, power through the last about 17 minutes. So harm reduction, right? So we're going to talk about harm reduction a little bit, and really everything I've been saying is more of a harm reduction approach to this. So it's really about doing no harm yourself and then lessening harms of what's going on. And then engagement really is how you do that, right? So engagement over abstinence. It's better to be connected to somebody, have a relationship with them, than to say, I can only work with you if you're not using. Because the chances are they probably won't stop using, right? Or they'll stop and then they'll use again and then they feel disconnected from you. There's a lot of research to show that engagement, even in treatment, is more important than abstinence or adherence to that treatment, right? So if I'm taking Suboxone and I'm coming every week and seeing the doctor and going to counseling and going to groups, but I'm also still using crack sometimes, some programs would kick you out, but there's research to show that it's better for you to stay in that program and still use crack, and eventually you will likely stop using crack, right? You'll be engaging in your recovery and you'll decide you don't want to keep using crack. The same even is true for if you're taking just Suboxone, you're not using anything else, but you're injecting your Suboxone. They found that if you start off injecting your Suboxone and you stay in treatment, you're more likely to switch to taking it appropriately and then stay in treatment. So there's a lot of myths around medication-assisted treatment. There's a lot of people that are misusing their medication-assisted treatment, but there's a lot of research to show that engaging them and keeping them interacting with a professional is more important than just discharging them back to using street drugs. I understand the ethical challenges of that because you don't want to be a doctor necessarily prescribing Suboxone that is either not getting used or getting diverted, because you have to be responsible for your licenses, which is part of why methadone is very useful, because the people are not diverting methadone. But I've said it a bunch of times already as well. So treat the whole person. We get fixated on either mental health symptoms or substance use symptoms, but start with treating like what the person wants to talk about. If they're interested in looking at different jobs or school or things, work on what's going on immediately, but also work on the other things they want in their life, because we as people are dynamic and we have many aspects of our lives. And for a long time, especially with active use, they've gotten lost in their use, and that has really become their identity. And if they really need to rebuild the rest of themselves or find the rest of themselves in order to be successful. And then know your limitations. I'm one person, I have hundreds of clients. Probably about 100 people are still on my client load. I can't see them all in a week or really even a month. I collaborate with a bunch of other professionals, interdisciplinary collaboration, medical people, social workers, police officers, and knowing your limitations, knowing what you can and cannot do and what your boundaries and ethics say you can or cannot do, and stick to that. Good boundaries are helpful for everybody involved. But also knowing what you're comfortable with in terms of harm reduction. Some people would be fine with transporting some needles to someone that's about to use, and some people are not. It's really what you're comfortable with, but also don't withhold options from people. If somebody's going to keep using, let them know about their local needle exchange. There's one in Portland, there's one in Bangor, right? We want to inform them so they can make a healthy decision for themselves. And then be aware of our own bias and values, and don't impose them on people. Before I started, I was actually pretty against medication-assisted treatment before I was in this position, because I had only ever seen it fail. And really, it wasn't the treatment that was failing, it was really the system of care that was failing the client. So I changed my mind very quickly, because then I saw a lot of successes, and I also saw a lot of people die. And dead people can't recover. You'll hear that a lot. And so I'd rather somebody be taking their medication-assisted treatment and survive and be working towards not using than tell them they can't use anything and have this huge risk of them dying while trying to engage in their recovery. And all of this is not to say that you cannot do abstinence-based recovery. Lots of people do, and they're very successful at it. I'm just sort of talking off some of the science behind opioid use specifically. And then if they're not engaging in what you see as treatment, engage with them around what they think treatment should look like, and don't just force what you want. So next slide. So we talked about this. The numbers are still going up, although the death numbers for 2018 in the Portland area have stagnated a little bit and decreased, which I think is just naloxone being more readily available. We're seeing a lot of new and different substances, almost all synthetic. We have spice in Portland, which is a synthetic marijuana. And the stuff we have here is much more potent and different than what you would buy in a normal head shop, and it makes people vomit all over the street. It makes them turn into sort of zombie people, and they have to smoke it about every 20 minutes all day long, or they get significant psychiatric withdrawals and some physical withdrawals. And then we're seeing a lot of benzodiazepine use, both prescription and liquid that they're buying on the internet with no dosing or any idea what it is, and also some pills that are being manufactured and then distributed that are non-officially manufactured. And then gabapentin is one that is thought of as by most doctors as harmless or not able to be misused. People are misusing it, or they're taking it with their opioids because it intensifies the experience. And so actually the DA is looking at scheduling gabapentin because they're concerned that it is being misused so regularly. Not that that's really going to help anything, but it's just something they're considering because it is being misused. And you need to withdraw from both benzos and gabapentin pretty slowly. Benzos especially, you can have seizures that can kill you. Next slide. Trying to make sure I get through everything in the last 11 minutes. So this is we already talked about most of this, but not a moral failing. 12 steps still have a lot of value, and there's a lot of community, especially in Portland, that does use the 12 steps. And I never tell anyone they can't use a model that they like or have already been successful in. Abstinence to me is the end goal. It is not the immediate goal. That once again, if someone wants to be abstinent, let's support them the best way possible. Medication-assisted treatment or medication-assisted recovery. The main three options are Suboxone, methadone, or naltrexone. Suboxone is mostly done in primary care or outpatient settings, although there's some IOPs, intensive outpatients, where people go 3 to 5 times a week. Methadone, there's 3 clinics in the Portland area. I actually like methadone a lot because people go daily dose. They are open early enough that if you have a job, you can do that as well. And the idea is that people are not leaving the clinic nodding out or intoxicated from that. And so I think a lot of people think that people are just nodding out from it. They're not supposed to be getting high from it. It's supposed to be helping with withdrawals. And naltrexone is one that we don't use too much in this state because it's so expensive, but it's a pill, and then you can get a shot called Vivitrol. And if Maine care expansion happens, we might see that used. The drug courts in California are using it fairly effectively. It blocks both alcohol and opioid receptors, so you can't drink and you can't get high when you're on it, no matter how much you try. And then just compassion for our clients and for the people in the community. Engagement is the biggest key, and then being aware of our bias and making sure that we can't necessarily change our bias, but being aware of it so that we don't allow it to impact too much of the work we do. So the next slide is going to be just to try the next few slides, just to try to convince you that medication-assisted treatment is good for people. This one is pre-treatment, in-treatment, and post-treatment. And the biggest takeaway is that both in treatment and post-treatment, less people are overdosing than before treatment. You'll see that the post-treatment, the overdose rates go up as well, which to me is a reason to keep people in treatment, because when they get kicked out of treatment, they tend to go back to using street drugs, and they tend to overdose as well. The next slide will also be similar information. This is Suboxone or buprenorphine and methadone comparison. So the rates of in-treatment risk of death are about half with Suboxone and about a third for methadone. So to me, once again, let's keep people in treatment, engage them in medication-assisted treatment. People don't die when they're in treatment, right? The reason I think out of treatment, and actually not why I think it's what the study says, the reason out of treatment is so high for methadone is traditionally people that engage in methadone treatment are at a higher risk before they engage in treatment and a higher acuity level. So that's how they account for that. But a half less people in Suboxone and a third less people in methadone are dying when in treatment. And the next slide is talking about chronic disease. I like this model, so I just throw this slide up there to entice people's curiosity. So these are rates of relapse among chronic conditions, and the takeaway is that basically every chronic disease has relapses, about anywhere from 30 to 70% relapse. So we need to really lessen the stigma and the shame that we put on people with substance use disorders. because it's expected that they're going to have symptoms, and we need to treat the symptoms and keep the person engaged rather than kick them out. I think of hypertension a lot. I have high blood pressure, hypertension. I was on a medication, went to the doctor. My blood pressure was still bad. The doctor didn't kick me out. He said, let's start another medication. We'll do 2 medications. And also, I'd really like you to lose some weight, exercise, and eat better. But he didn't say, unless you lose weight, exercise, and eat better, I won't give you meds, right? He said meds first and then work on your behavior. And we do the opposite with substance use disorders. If you're not abstinent, you got to be abstinent, or I'm not going to give you this medicine. We need both, but we need to give them this medicine, if they're asking for it. So rapid access to treatment is the next slide. This is a new thing in Maine. Midcoast Hospital is doing it. A couple rural hospitals are working on some grants to get this going, and Mercy Hospital is also in the process of working on this. Basically, if you go in with an overdose or withdrawals, they will rapid access you to Suboxone. They'll dose you in the hospital. You'll meet with some recovery coaches or peer support people, and then you'll have an appointment at a primary care office within a day or two. And if you need more Suboxone in the meantime, they will dose you at the hospital until you get access to that primary care. So this is a harm reduction approach from the hospital system. Mass General Hospital has been doing this for a while. They do both methadone and Suboxone with a lot of success. And I'm glad to hear that Portland is going to try to do it, and that Midcoast has already successfully been doing it. And then the only thing is, people really don't fail their treatment. The treatment fails the people. It doesn't figure out what they need and help them work through it. All right, next we're going to power through some naloxone stuff. So if you're not familiar with naloxone, it has a lot of press. Most people are familiar in some way, or Narcan. But it's an opioid antagonist, which means that it kicks the opioids off the receptors in your brain, and it only works on opioids. So if you have other chemicals in your brain, it's not going to work on those. So that's why it's important if you're needing to reverse an opioid. Oh, sorry, I missed a couple questions. MAT stands for medication-assisted treatment, or methadone-assisted treatment is fine as well. It's really, MAT is anytime we're talking about MAT, it could be Suboxone, methadone, or Vivitrol. No, I think that's I'm just looking at the question about research. I think that's the most up-to-date data that they have. That was cited at a presentation that I viewed last year, and that was the most current data they had on that. I think Mass General Hospital is putting out some data on their programming, but they haven't published it yet. And that's the problem, is there's a lot of delay on publishing data. And then it's safe for people of all ages. You can use it on babies. It will not harm people if they don't need it. You can get it from a doctor's office with a prescription right now, and then it's very close to being available over the counter. The Board of Pharmacies figured out some regulations, and then pharmacies will start stocking it, and you'll be able to get it without a prescription at the pharmacy. They'll over the counter, they can do the training, and there are several different preparations. One preparation of it is covered by almost every major insurance, and if you want the nasal injector, the nasal spray, self-pay is about $75 for 2 doses. So it's not affordable, but it's a much cheaper than, it's not out of the price range for most people to buy a box of 2 doses. And it saves lives, and it does not enable use. And people are not having, those, you hear like Lazarus parties where people are using as much as they can and dying and using naloxone to keep themselves safe. That has not been my experience. That's not what people are doing. People are, they're carrying naloxone and saving their friends' lives because they're struggling with their use, and they don't want to die, and they don't want their friends to die. And the only way really is, CPR and naloxone. And it's such a simple tool that it's almost frustrating when people do die, because this one medication almost always works, right? There's very little complications. You can have something happen in your lungs where your lungs fill with fluid from the reversal of the overdose, which is very rare but needs medical attention. All right. So 3 minutes left, some practical solutions, and then, at all agencies and all levels of care, adopting a harm reduction approach and attitude is valuable, and that's a range, right? That goes from anywhere of being, hoping that legalization happens and people can use as many substances as they want, and they can also receive treatment that would maybe be funded by that taxes from those things, or it could be, you're okay with someone being on medication-assisted treatment. There's a range, right? The biggest thing is really doing what the client or the person that you're working with wants for themselves, even if you disagree with that being the best option. And that is, that comes from my wellness counseling philosophy. I'm not here to tell people how to live their lives. I'm here to help them figure out how they want to live their lives and then support them. And just because I disagree with it doesn't mean that I'm right and they're wrong. And most often they will learn that, what they did right and what they did wrong, and they'll have a conversation. I had a guy, overdose 3 times in one day. He did the same plan again. He overdosed 3 times in a day, and then he said, I think I should do a different plan. And now he's in recovery. So I'm going to do what they want to do. And I think that we as a community support people in their decisions, because we need to have belief that they want good things for themselves, and then help them talk through problems, right? Motivational interviewing is a sort of a buzzword, but I recommend it for all people, not just people that are professionals, because it's a treatment tool. It's not a modality, so you don't need to be a clinician to use it. It's about engagement. It's a good training for anyone, not just clinicians. Person first language is something we talk about all the time. If you don't have resources, saying person with substance use disorder, person with, I'm not hypertension, I'm a person with hypertension. And then not saying substance abuse, right? So substance abuse went away with the DSM-5, so we should be calling it substance use disorder and using appropriate language and correcting people when they're not using correct language. And then reducing shame and stigma with your actually using correct language, not being imposing our wills on people, and collaborating with law enforcement when appropriate. Don't be afraid to utilize them for mental health and substance use related calls. It could be pretty scary at first, but then you get comfortable. And 30 seconds left. The last 2 slides. The last slide is just some more content if you're interested in consuming some. Most of them are YouTube videos, which are not less than scientific, but are interesting thinking points. The first one is a guy talking about addiction. The next one is the chief of police in Portland doing a TEDx talk. Rat Park studies, Bruce Alexander from Canada. He has a lot of research on socialization and things like that for protective factors. Police assisted addiction recovery is out of Massachusetts. They have a lot of law enforcement stuff if you want to look at that, but they also have a lot of the Mass General stuff. The Mass General Hospital came and presented their 2017 conferences available free at that website. I recommend digging in if you're interested. And then if I didn't get to your questions, or you disagree with something I said, or you want more information, my email is at the last slide. I'm always happy to have a conversation or a debate. I'm sorry we didn't really get a lot of question time. It is now 2 o'clock, so I will stop talking.
Okay, so we still have a lot of people on the webinar. If you do want to chime in with any questions, you can hit the *6 to do so. Go ahead and just start to close out the webinar. And I really want to thank Oliver today. I know you spent a lot of time developing the content and the resources, and this is kind of the first time this presentation was put together, and we really appreciate you taking the time to share your knowledge and your experience with the broader community. We are planning to rerun this webinar, a live version, in the fall or in the winter of next year. Oliver has agreed to do that since we had so many people interested. So if you are listening today, but you did not register, what that means is that only people who registered today can qualify for continuing ed. But if you want to take the webinar in the future, because you listened today but don't qualify, then that's your opportunity to get the CE for this. So again, if you are in the workshop today and you're looking for a certificate or any form of continuing ed, please sign in the chat area using your name and your email. I'm going to send out a survey for people to complete. And then once we have enough surveys completed, I'll be able to email out certificates. Anyone who's looking for continuing medical education is mandated to complete that survey, and your certificate will be mailed out once your survey is completed. If you have any questions for AdCare, you can email me, J Mehorter, JMEHORTER @adcareme.org. And we appreciate everyone joining us today. And I think most people are signing off, but if you do have any questions, feel free to sign on and ask them. I'll leave it open for a little while longer. Okay, I'm going to go ahead and close the recording.